to Researcher Revealed. I'm Dr. Rosalind Austin. This is the podcast where we go behind just the name that's listed as an author on a paper or poster or presentation at a conference in order to discover who is doing that research, why, and how they became a researcher. On today's episode, we have a researcher joining us from Wales. Emma Rees is a cardiac physiologist, and she's particularly interested in the use of ultrasound through the technique of echocardiography in order to better help early identification and diagnosis around issues with somebody's heart. She shares with us today how she got into research and how she's become an international researcher who's looking at both pediatric heart conditions as well as individuals who are at the latter stages of their life within care homes. It's an interesting episode with lots of great tips, so do enjoy. Hello, I'm Dr. Rosalind Austin, and on this week's episode of Researcher Revealed, we have the very lovely Emma Rees joining us from Wales. Emma, can you say hello to everybody and just give you a quick introduction to who you are and what you do?
Yeah, I can. Hello, thank you for inviting me on. So I am a clinical academic at Swansea University, and my professional background is that I'm a clinical scientist and I specialise in echoes, ultrasound heart scans. So my job is a bit unusual because it's split between clinical work, teaching and research.
Okay, so just for everybody out there who may not understand a couple of the words that you just said, what is a clinical scientist and what is echo?
Okay, so a clinical scientist is really, in my profession, somebody who specializes in investigations that diagnose, a disease or that look at physiology and how that changes with aging. And we, in cardiology, will focus on cardiac tests. And as we get more senior, typically people will pick to specialize in either ultrasound scans or rhythm management and implanted devices. And so my specialty is in ultrasound heart scans. So I see a range of patients, all adults. Adults is the focus of my work. I don't do pediatrics. And generally speaking, they come in with symptoms like chest pain or breathlessness or palpitations. And we do the ultrasound scan as part of a range of tests to help the medic decide, is there a cardiac cause of the patient's symptoms? And if so, how bad is it and what should be done about it? And then if there is a cardiac cause, patients will often come back after they've had some management or intervention, and we'll have a look at the impact of that.
Ah, perfect. I'm going to say that clears it up quite a lot, which is really good, just to make sure everybody out there listening is on the same page as you and I. I want to ask you more questions about the clinical academic aspect of your role and what you do research and teaching wise. But if I start down that lane now, we won't do the rapid 11. So first and foremost, we got to go through our rapid 11 questions. Are you
Okay,
ready?
kind of, yeah. I'm not really
I think
sure
not
what a
that
rapid
scary.
11 is, but let's go with it.
Oh, quick little questions just about who you are and how you work. Nothing too personal, nothing too scary.
Okay.
Question number one, are you a Windows or Mac user?
Oh, Windows. Yeah, I've
Okay,
never tried a Mac. No organization has ever given me one, so Windows is what I use.
fair enough, fair enough. It's definitely the majority. Do you drink tea or coffee?
I drink both. Coffee in the morning and only if it's good, and then tea the rest of the time.
That's brilliant. I love it. So I'm guessing good coffee takes away from the instant coffee that the NHS
Oh,
provides.
yes. Yeah. Yeah. It's not worth having. I'd rather have a cup of tea if the coffee's not very nice.
Yeah, fair enough. Um, where do you tend to work?
Uh,
Home
a,
or
mi
office?
a mix of places, probably home less than office. So home maybe 2 days a week and then office the rest of the time.
Okay. When you're writing or working on your research, is it a silent environment or is it a music or sounds?
Ah, I'm a silence person, not just
Mhm.
when I'm writing. I just love silence. I'm one of those people who loves just quiet. And I
Ah,
get, I can get quite overwhelmed if environments are too noisy or busy. I need to go and retreat to a quiet space. So yeah, silence for me. And I one task at a time is how I
oh,
like to focus on one thing and really, really spend quite a few hours on one thing. I don't like to chop and change between things very much.
that's very fascinating. We might come back to that and when we talk about clinical academic, because being a clinical academic requires you doing multiple things
It does,
simultaneously.
but
So I'm a bit
not at the same
intrigued.
time, generally.
No, like I said, save it, put a pin in it because I want to come back to it. Um, right. What time of day are you most productive? Not like the hour, but like morning, afternoon, evening.
Oh, first thing in the morning. The earlier the better.
Ooh, silent and early riser. I like it. What is your favorite management system for references?
Really? That's a rhetorical question, right? I definitely don't have one. I am not very experienced at using different types. I used EndNote in my PhD a few years ago, and I've stuck with that because I felt like I didn't have capacity to learn something new. Um, yeah, I'm pretty short of time, so learning new software is something that is a bit challenging. So I use EndNote. My
No,
colleagues have tried to persuade me that Mendeley is better. Somebody's mentioned Zotero. I haven't tried them.
fair enough. Fair enough. I've tried Zotero. Yeah, Zotero. And there's bits about it that I like, but similar to you, I haven't given it the dedicated time to try and figure out like the more complex things that I really like EndNote for. I'm defaulted back to EndNote. Right. What about the software tool that you use to create any like images, graphs, figures in your publications or presentations? What do you tend to use for that?
I think I'm quite basic with the graphs and things that I produce. I like simple. I think simple is often better.
There's
So
nothing
I'll
wrong with that.
Yeah, I think I'll probably go with, my tendency is to go with whatever package I'm using to do the statistics. So
Okay.
typically that will be SPSS.
Okay.
However, I've just started doing some big data science analysis, and for
Mm,
that, I have funding for a data analyst. And so they provide some data visualization of the large data sets. I'm not sure what they use, but obviously it's far more, it's got far more options and bells and
yeah.
whistles than what I'm used to. I've heard that Tableau is meant to be good for really large data sets, but I've
Mhm.
not looked at that yet. But it's something I've
Interesting.
thought of looking at.
I'm just like, so my reaction to your answer there and the fact that you have a person that is like a research career goal of
Yeah, I
to
think
have somebody that I can be like, look, I want it to be pretty. I want it to be this color scheme, and I want it to tell me what the data tells me. Go.
Yeah, I mean it's tricky because sometimes the person that you're working with who's a data analyst doesn't have any clinical knowledge and doesn't
Mm,
necessarily understand
interesting.
the message you're trying to get across. So you do
Yeah,
have to work together,
yeah,
but they'll sometimes come up with suggestions for how the data could be presented that you won't have thought of because they've used it in other projects or other
yeah.
types of other disciplines even. So yeah, I've only just started working with them in the last year, but yeah, it's good and it's shown me how important funding is.
Exactly. Oh, that's brilliant. I love that. On to something a little bit more fun. Other than software programs and doing all the hard work of research, is when you're sitting at your desk, do you have a favorite desk snack?
Not really. I'm not,
No.
yeah, I'm more of a big meal, a couple of times a day sort of a person. I don't snack very much. I think if things are a bit stressful and I need a snack, then I'm likely to reach for something that's either got nuts and dark chocolate in or something that's a bit bitter. I don't have a sweet tooth. So I'm more
Oh,
likely to snack on something savory than something sweet.
nice. I like it. I like it. Right, almost there. A couple more questions. When you're planning or organizing, whether that's like an outline of a paper or a project or grant application, are you a pen and paper person or are you a digital planner person?
Probably a bit of both. I think in the earliest stages, pen and paper.
Hmm.
And then as it starts to take shape, I want it digitally because I don't want to waste more time writing with pen and paper when I could be putting it down,
Yeah,
in the
yeah,
media that it needs to be in ultimately.
yeah.
So yeah, probably pen and paper in the very early stages and then moving to digital fairly quickly.
Perfect. Love it. What book are you currently reading?
I am not reading a book at the moment.
Fair enough.
I generally will only read fiction on holidays, and I
Ooh.
don't read many non-fiction books or textbooks. I'm tending to read more papers, but I
Mm,
have recently come back from holiday. So I read, I can't remember who the author is, a book called Orbital.
Orbital.
Yeah, it's really a very different novel and it's very short. I'm not sure I would call it a novel, but it is a work of fiction, and it follows a few stories of astronauts on a space station orbiting the Earth. And so it's more like a collection of individual stories from the perspectives of the people in the space station orbiting the Earth. And I picked it up because it was quite slim. It caught my attention because it was quite slim, but also it was quite critically acclaimed for being
Hmm.
beautifully written. And I
Ah.
wanted to try something, that I might not normally pick up. And it was interesting. I can't say I loved it. I marveled at how beautiful the writing was. I could see
Okay.
the skill and the emotion that the writing created
Yeah.
was very fitting for the things that were happening in it.
Yeah.
It was very beautifully written, but I like a book with a bit more of a complicated plot. And
Ah.
this was more about individuals' stories
Yeah.
of the people who were in the same
Yeah. Yeah.
location.
Yeah.
I missed having a decent plot to get my teeth into. So it was
Fair enough.
beautifully written, it's highly acclaimed.
Yeah.
I don't want to detract from it, but I felt like it wasn't quite me.
Fair enough. I think that's the genius of reading different things and challenging yourself to step
Yeah,
outside of your comfort zone is exactly that, is you get to know what you like and don't like better. So very interesting. I'll put that on the book
interesting.
list. And the details for everybody out there listening will be in the description so that you can find the book that Emma was talking about if it sounds like you. Last question is who is a researcher that you admire?
Blimey. uh, So there aren't really many researchers in my field, and I would love
Mm.
to say that there are a lot of people who've gone before me in my field who I admire. So I think probably the people that I admire who've kind of gone before me and helped me are not in my field. So Professor Chris George is a molecular cardiology professor, and he's kind of really helped with my confidence in stepping up to research leadership roles. And
Wow.
then Professor Julian Halcox and Alan Fraser are cardiologists, and they had never supervised somebody from my profession to do a PhD before. And I
Yeah.
was the first in Wales from my profession to do a PhD in the field.
Wow.
And so they really took quite a gamble quite a few years ago now on me doing a PhD in cardiology, and that I learned a huge amount from them. So from Alan, I learned the devil is definitely in the detail, the method is everything. And from Julian, I learned never to lose sight of the bigger picture and to challenge myself to think bigger, which in the beginning, certainly I struggled with. But now I think probably I admire my contemporaries. So anyone who's doing a PhD in cardiac physiology, who's done a PhD recently, who I know, so people like Maria Payton at Leeds, for example, or James Willis at Bristol, Emma Lane, who's in your neck of the woods. So yeah, anyone who's really pushing the boundaries of our profession and trying to encourage others to be research active. And there are others that I haven't mentioned, but yeah.
Oh, I'm sure there's like most people when I ask that question, they're like, and you get going, and I'm like, no,
Yeah.
no, we only have an hour. We gotta move on. Um, but I think like your answer there has that's all the Rapid 11 done now. But I think your answer has really opened up exactly the reason why I wanted to have you here on the podcast. I didn't realize you were the first in Wales to do a PhD with your clinical background in cardio. That's well done. That's
That's
really
as far as I
cool.
know. Nobody's told me otherwise, and I'm a bit long in the tooth now, so I'm assuming I would have known if I was giving out misinformation. But yeah,
Well, to the best of your knowledge, we'll
yeah,
bracket it. We'll be researchers and bracket it to the best of your knowledge. And, you mentioned, because you're one of very few within this clinical expertise, that's a very crucial part of people's health journey within cardiology. Um, to be doing and leading on research, that you don't have those mentors, that you don't have those people who you can lean on. So, how did you, if you don't have those mentors within your professional group, how did you wake up one morning and go, you know what, my day job is boring as. I can't think of anything better to do with my life because my life is boring as well. That I'm going to be completely consumed with the pursuit of a PhD as the
yeah.
first person, to the
As
best
you
of your
might
knowledge, in
imagine,
Wales. Like, how did that happen, lovely?
as you might imagine, it didn't happen like that. So it it was quite a long organic process, is what I would
Okay.
say. So I loved my job in the NHS. I worked in a big cardiac centre at Morriston Hospital in Swansea. I worked there
Mm.
for 10 years and, got to quite a senior level. And really enjoyed it and was teaching people on the job. Others, more junior members of
Yep.
staff would
Yeah,
come
yeah, yeah.
along, and then occasionally I'd get asked to give talks to the junior doctors or some of the
Mhm.
nurses, and thought, oh, I quite like doing this. I quite like explaining things and trying to make them the information that might be complex as accessible as possible. I was enjoying it and getting nice feedback. And then one of the cardiologists said, there's a job going at the uni and they're looking for somebody to help run and teach in the undergrad program for my
Okay.
profession. So
Okay.
he said, "Oh, I think you should apply for it." And at the time, I felt real loyalty to my department,
Yeah.
who'd invested a lot of energy and money in my training, and I thought, oh,
Yeah.
I feel like I can't leave. But my head of department at the time was brilliant because she had obviously spotted something in me that she felt like I needed more support and more of a challenge and more of a push to
Okay.
grow. And
Okay.
and she actually said, we need you here, but in Wales, we need you there. So she said, I
Wow.
think you should go. I think you should apply for it. And what we decided was that I spent 2 days a week still at the hospital, and I
Mm-hmm.
went to teach 3 days a week. So I had this
Mm-hmm.
split contract. So right from the
Okay.
outset, I had this
Wow.
keeping my clinical role and then going and teaching. And then I became the program director of the undergrad degree, which really needed more time, and I needed to grow the team and all of the rest of it, try and get more money in and try and improve our commissioning numbers and all of the management stuff that goes with
Yeah.
that. So I dropped 1 day a week in the hospital, so I became more academic than clinical. And then after a while of working in the university and teaching, the kind of natural scientific curiosity that often comes with our professions,
Hmm.
I just felt like there was an itch that hadn't been scratched,
Oh, that's dangerous.
I felt a bit like I'm not really achieving what I feel like I could in terms of, I was always asking questions about, well, why do we do it this way? How do we know there isn't a better way? Or if there are several solutions to a clinical problem, how do we know which one to pick? And what happens in the system as a whole if we pick one that's not so good? So how does that
Yeah.
impact the wider system? And there were lots of questions that I thought the research that was being published wasn't really answering, certainly not from the perspective of a clinical scientist or a cardiac
Yeah.
physiologist. So I thought, you know, maybe I could do a PhD, but I wasn't really sure academically I had it in me,
Okay.
to be honest, at that point in time. So, reading more and I became more interested in the earliest signs of cardiovascular disease, particularly in women, and
Mm-hmm.
how we could use ultrasound tests to diagnose things at an earlier point. Because normally, in the NHS, with the best will in the world, we don't get people often as early as we'd like in the disease process. We wait
Yeah.
until they're symptomatic and then we
Yeah.
react.
Yeah.
And yeah, we could do better and there's moves to do better. But I felt like actually women with hormonal problems or insulin resistance or who were struggling with their weight, perhaps if we could understand the development of cardiovascular disease in them earlier, it might help us understand how we could intervene sooner. So I started to develop some ideas about how we could use ultrasound testing and some new measurements. And my idea was really to look not just at the heart, but the heart and the arteries and body composition and metabolic function together.
Yeah.
So thinking about it from an interdisciplinary point of view, not just the silo of the
Yeah.
heart, which is what we normally do. So I just really thought, I'm going to have to be gutsy here. People aren't going to come and offer me a PhD. There was nothing being advertised in my field. So
Yeah.
I literally just emailed a consultant cardiologist who was a professor and said, I'd like to do a PhD. I'm interested in this. Do you think you'd supervise me? And he was at a different university. And he said, why don't you come for a chat? And I went for a chat, and then he called another professor into a later meeting who was a heart scan expert. And yeah, I worked up the idea and somehow it became my PhD. Um, and then that was I finished that a while ago now. When was that? 2016,
Mm-hmm.
2016 I
Yeah.
graduated. So and then since then my research has just developed and grown, but it is still ultrasound scans and it's still interdisciplinary in nature.
Yeah.
And it very much focuses on, what a clinical scientist can add in terms of value to the diagnostic process or the management process.
Nice. Thank you so much for sharing your story. I think like there's some real gems in there about what scientific curiosity will lead you to. And you said at the beginning when you were talking about your heroes that one or researchers that you admire, that one who you currently admire is helping you with confidence. But I don't think you give yourself enough credit because to have the confidence to blindly cold call slash cold email a professor in a separate university and be like, hi, like that's huge.
Yeah, I feel like it came about because, so I was in my late 30s at the time, And I
Mm-hmm.
realized I'd been working in the university for a while and I just wasn't getting anywhere. I felt like it didn't really fit in. I didn't have a typical academic track record or mentality. I was different. I just didn't fit in with other people around me. And I
Hmm.
got to a point where I think I realized I've got to stop waiting for somebody to direct me, which is what often happens in the NHS. You are
Yep.
directed,
Yep.
or and I need to stop asking for permission. So I just thought, okay, I'm just going to go and ask. And if they
Yeah.
say no, they say no. I won't have lost anything. I won't be any
Yeah.
further behind than I am now.
Yeah.
But at least I'll know, and
Yeah.
I'll hopefully, even if they say no, I'll have had some feedback around why and where my
Yeah.
gaps are and what else I might need to do to start that journey. So I think it was literally just, I reached a point where I went, I'm going to stop asking for permission. I'm just going to go and do it. And I think that, yeah, that's what made the difference really. And the confidence has come since then.
Yeah.
So, I
Well, it has
felt like
grown. It's
definitely,
grown.
it's definitely grown. I feel like I was always apologizing for not being a medic and not being a career track academic. So I would always introduce myself as, a clinical academic or a clinical scientist, and I'd always go, I'm not a medic. I've stopped doing that now. Because it,
Okay.
it felt a bit sort of, I'm just a clinical scientist or I'm
Mm,
just an echocardiographer.
yeah.
And then, people respond to that, I think, by perhaps in some forums not giving you the respect that your expertise might warrant. I
Yeah.
feel like respect is very much earned, and I want people to
Yeah.
judge me by my actions, not
Yeah.
by my length of experience or title or
Yeah.
whatever. But I
Yeah.
do feel like there's something around not apologizing for what you're not. I know that's a double negative, but it's that sort of, yeah, I am a
But
clinical
I think,
scientist.
like, again, without getting on, like, um, what's it called? Soapbox. I think being female, being non-medic, like coming from a nurse background, like we're always, and also
Mm.
being Canadian, like always
Yeah.
apologizing for the fact that we exist. Right. And I think like that's such a big thing to overcome because when you
Mm.
present your first impression being like, oh, I'm sorry for who I am, and that then leads those other people to be like, well, why are we apologizing all the time? And it sows, I believe anyway. I'm trying to cut it out of my own life. I'm not very good at it though. Um, it leads to planting seeds of, well, do they have a reason for
Mm.
apologizing for being this, that, or the other thing? But I also think system wise and structure wise, you know, it's kind of beaten into us a bit as well.
But
Like
it does
I'm
stop
going to use
us.
nursing as an example very quickly. Is like if you go into advanced clinical practice as a nurse and you become a prescriber, you don't become a prescriber, you become a non-medical prescriber. So your job title apologizes for the fact that you're not, you know what I mean?
Yeah. And I think the key thing is that, there's value in being a clinical scientist. I'm not trying to be a
Mm,
medic, and I'm
yeah,
work at advanced practice level. I've never, patients are always very clear about what my role is and, what the strengths of a clinical scientist
yeah,
are. But I think I became aware as well that if I was around people who were studying undergrads and postgrads, I didn't want them to see that I was apologizing for being not a medic. So
yeah,
I think it was that whole, as I've got older, I've become more aware of the, I don't know, the ripple effect on people around me. And also, you know, being offered a seat at the right table for decision making does require that a bit of professional confidence and not apologizing all the time. So, and having confidence in who I am as a clinical scientist. And there's so much I don't know. You know, it's a huge amount. The more experienced you get, the more you realize you don't know. Yeah. So there's so much I
Definitely.
don't know, but I'm more confident now and comfortable in saying I don't know.
Yeah.
You know, I'm happy to say it now, whereas 15 years ago that might have been a bit more awkward for me. I might have felt a bit more uncomfortable with it. So yeah.
Do you think, again, not just the role of your mentors and supervisors and things, do you think the fact that you did and you focus on interdisciplinary research has also fueled that perspective a little bit? Because, like you said, um, I've definitely learned in my research career, because again, not because I'm the only nurse in the world that ever does research, but because where I am locally, it meant like my primary academic supervisor was a sociologist. I had a nurse on there as well, but then my clinical supervisor was a consultant,
Mm,
medical doctor. And their perspectives altered and shaped how I think about research,
mm,
how I deal with data, how I write up data, the kind of analyses that I will even consider doing. You know, all of those, the robustness of the work that I do, all of those things definitely sharpened me, I believe, more than if I'd only been surrounded by people within my profession, because they see things differently. And those different visions really change how you think.
mm.
Was it the same for you?
Yes, I think there's a few things in that. So first of all, if we're doing clinical research,
Hmm.
we're thinking about the person and their experience of the whole healthcare system, and the impact that we have changes the rest of the system. Just doesn't just
Yeah,
change the bit we do for that person. And so we need to understand how the different disciplines that that person will come into contact with might view the work and what concerns they may have. We need to listen to those concerns and think, okay, well, yeah, how am I going to overcome that? Or what evidence can I collect that will help that person in their role? So there's something about the interdisciplinarity leading to better research for the patients or members of the public by having different perspectives of the system. But then there's also understanding that each person and profession will have different expertise around methodology. So, for example, when I started in my PhD, I'm all about physiological measurement and numbers, all the biological data. And that's what I was comfortable with. And actually, what my research needs in terms of ultrasound being embedded better into systems in different places, what that needs is mixed methods research, and have to be very, very aware of implementation science and patient safety. And those are things I had no experience of or knowledge of. I didn't know what the frameworks were, the theories were, which method might best suit the project that I was doing. And so going to speak to different people and different professions, I started to learn, oh, right, okay, there is a way that I could do this that would be robust and would stand up to scrutiny. And I need to go and read more about that, but they would shape that understanding. So I think it's both in terms of the research methodology and in terms of multiple perspectives of the same clinical challenge, because
yeah,
all the research that I do stems from a real world clinical challenge, and that's not
yeah,
just faced by my profession.
yeah. I preaching to the choir.
Yeah.
Is the truth of the matter. But I agree with you. I think, you know, somebody's experience and their pathway through the healthcare system is complex. And, you know, I'm going to throw a stone because it's kind of an easy stone to throw. You take fill in the blank pharmaceutical study in cardiology, not in cardiology. They couldn't be more simple if you
Mm,
tried. And they'll have layers of complexity in them, but basically it'll be, does this pill work? Is it safe? Does it hurt people? But it's not how do people take the medication? What does taking the medication mean? Where is the best point for them to have the consultation about the
Yeah.
medication, all of those other things that are really important to that person wanting to, being happy to, and remembering to take that medication. It's not just, I had a psychology professor who always challenged me when I was in a previous lifetime. And he said, if you create a pill that will cure any cancer, what good is it if you can't swallow it?
And I think that the key thing there is we need both. You have to
Yeah.
have that robust sort
Oh,
of
yeah, yeah, yeah,
safety
yeah.
dosing study, but you need more than that, don't you? So yeah,
Exactly. And I think it goes to like what you're saying about your research is it's in order for the numbers and the techniques that you use to try and better characterize heart function in a way that is less reactive and can promote better health in people. Yes, those absolute numbers and knowing that this technique and that measurement and that variable are those key things. It doesn't take away from that importance, but if nobody can do the test, the equipment isn't in the community, there's no access to it, then
or nothing changes as a result of the diagnosis. If there's no
exact,
action taken,
yeah,
a diagnosis on its own doesn't change outcomes. So,
no,
you have to understand what are the
exact,
downstream impacts of it.
yeah, yeah, no, cool, I like it. So, what if you can now on in the complex world of research for everybody out there who's at the what I call the research curious stage. So you might
Yeah.
be asking some questions, but you don't really understand it. In research, there's a lot of times that we can't talk about what we do or what we're doing. But just generally, are you able to share at the minute with where your career is at? Like, how has your research focus shifted since doing your PhD? And what are sort of your hopes and aspirations for research, not just for yourself, but for your clinical professional group in general?
Yeah. So I think personally, I've moved from small data sets of physiological measurement in a group of people, and it's almost sort of hypothesis generating, that research. It was like, well, do we understand whether the hormone abnormalities are more important than being overweight, and which of those has the biggest influence on cardiovascular function, and generating some hypotheses from that. And now my research has moved more into what I feel fits with a clinical scientist perspective, which
Okay.
is I, in a specialist centre, can do ultrasound heart scans with really high quality. And the
Mm-hmm.
patients that get referred to cardiology, they get exemplary care often. But what about the ones who aren't referred to cardiology? And
Mm.
what about the ones who don't have the heart scan because either they have struggled to access it, or they can't get to hospital, somebody hasn't referred them for it, people haven't picked up that their breathlessness might be the heart and not something else. What about those people? And I started to think more about healthcare inequalities and inequalities
Okay.
of access, and
Yeah.
thinking, well, the patients that I see, great, they're all fab, they're all having the best care they can possibly have, generally.
Yep.
I mean, we can always do better, but you know what I mean. But
Yeah.
there are a
Yeah.
whole tranche of people out there who I felt really weren't getting the same quality of care. And those the things that have sparked my interest have been the very oldest in our society,
Mm-hmm.
who are perhaps receiving care in their home or in care
Mm-hmm.
homes. They
Yeah.
often carry the largest burden of disease, but they have probably the poorest access to specialist care.
Yeah.
So those individuals, I feel like we could do better with in terms of cardiac diagnostics and tests.
Yeah.
And then also people living in remote or low resource areas of the world where there aren't cardiologists or there aren't clinical scientists. So I've started to really pursue research that is thinking about possible solutions for bringing ultrasound into those places. So on the one hand, in the UK, in Wales, I have a fellowship project, which I'm halfway through, which is looking at teaching advanced practice nurses to do handheld ultrasound scans of the heart and lungs for older people who are receiving care at home. And the idea is if they've got acute breathlessness, that the nurse is better able to decide, is this likely to be the heart or the lungs or anemia or something else? So it's bringing ultrasound scan of the heart and lungs as a triage test to the bedside, but it's not in hospitals. And my research is really about, is it safe to do that? Is it the best solution? Does it really add to what we do now in advanced practice? Because these people already have some point of care tests. They have a blood test and they have an ECG recording and that sort of thing. So does it really add to that? And does it change the nurse's decision making around who to admit and where to admit them? So there's that project. And then at the other end of life, I'm working with an American med tech startup company to develop and test a screening device, ultrasound device for newborn babies. So the idea is, at the moment, you're probably aware, you've seen it on Casualty or a TV program, I'm sure. When someone does an ultrasound scan, they hold a probe and they have to manipulate it. And that actually takes a lot of skill and experience to get the right views and all the rest of it. And then they have to interpret the images to make sense of what's going on. And that's even harder. So at the moment, the problem is if you live 3 days away from a hospital or a specialist, understanding whether your symptoms are, or your signs, your clinical signs are because of your heart or something else can be quite challenging. And newborn babies who are unwell might need to be put in a car and travel for many, many hours to get to a hospital to have a scan that then shows it's not the heart. And you could have had treatment for this more locally. So the idea of the screening device is that it's a put on in one location, don't move it. And it steers the ultrasound beam through a sweep of the heart and records it. That can then be remotely sent to an expert to review. And the next step in the development is to see whether we can use AI to separate normal from very abnormal. So again, this is triage. So the focus is on using ultrasound as a triage step. It's not going to say this baby has this cardiac abnormality definitively.
It's just this baby needs more focus.
This baby, you probably don't need to worry about the heart. This baby, you really do need to worry about the heart. Send them for more detailed tests. And so in both cases, it's really about trying to get ultrasound to community locations, primary care locations, to be used by non-specialists, but in a way that very carefully considers patient safety, the risk of missed diagnosis or misdiagnosis, and how we can minimize that and make sure that there are appropriate escalation procedures in place and that people are using it in the right way. And of course, if it doesn't add value to what's done now, we'll say you shouldn't do this. I'm not so invested in it that I think this is the solution and I'm going to find a way to demonstrate to everybody. I'm very much, it's a possible solution that if done well might work, but we don't have any evidence of that at the moment. Like, we know that ultrasound in the hands of an expert, even the little handheld machines, are accurate. There's plenty of research about that. But what we don't know is, what if we move it and put it to somebody who's a health visitor, or somebody who doesn't have cardiology expertise? Or what if we put it in a system where they can't just call the cardiologist and go, can you have a look at this?
Exactly.
What happens then? So it's about the implementation of it, where it is, who's using it, what training do they need, what support systems do they need, and what are the impacts on the rest of the system. That's what the research has moved to. And that's what the focus is at the moment. So both ends of life,
I
but
was going to
probably
say,
both places where there are current inequalities in care.
but I was just going to say, like, I absolutely like found that fascinating to hear sort of like the things that you're working on because 100% like similarly, I think like with my PhD, I thought, oh, I'm gonna figure this, that, and the other thing out. And all it did is really show me those health inequalities that are out there in terms of our healthcare services. And loads of other people I've spoken to on the podcast are saying the same, is it highlights even more so where there's need for improvement. And I think, you know, looking into those two very different and yet very similar, not pathophysiologically, not illness wise, none of those things, but actually they're very similar communities in that their access to care is hampered by factors that they really can't change or control. So, for example, somebody who lives in the middle of nowhere because that's where they were born, they didn't get a vote about where they were born or where their parents live. Should their care be different just because they live in the middle of nowhere?
Mm.
And on the flip side, you know, those here in the UK, I've seen it so many times as a nurse where people who are in care homes are their access to care is slow. And so by the time they get to the hospital, they're usually really sick because their care homes will kind of like muddle through, but there's certain lines that those care homes can't cross. And by the time that you find out they're ill, they're really ill. And
Yeah.
it makes their potential outcome that much harder to be, even when you give them excellent care and excellent diagnosis. It makes it that much harder for them to have a positive outcome. And there's, yeah, a real need to try and, again, like you're speaking to my passion project because I'm like, you know, the healthcare works great for people who've got the ability and the strength to advocate for themselves and to seek help and to be able to navigate the complex healthcare system, regardless of whether that's England, Wales, or somewhere in Africa. Healthcare system is not easy to navigate.
No, and I think, you know, in Wales certainly, and I know it's the same in the rest of the UK, there is a problem with a high level of unscheduled admissions and emergency care. And for older people particularly, we know that once they come into hospital, they are their physical mobility and their cognition changes the longer they're
Yep.
in. And then it's harder to get them out because their social care needs have changed.
Yep.
So prevention of coming into hospital, if possible, by trying to target those with heart failure or heart disease earlier so that they're not right in the extreme situation of, you know, lungs full of fluid, I've got to come in, then, you know, that's always going to be better. Keeping them in
Yeah.
their home is always going to be
Yeah.
better.
100%. So a couple of quick questions, and then we're probably going to have to wrap up because time has just gone like disappeared. Um, so you mentioned you're shifting towards big data sets. What initiated that, and how are you navigating that shift? Because there's quite a demand at the minute for everybody to shift to big data sets, and it's quite a big ask if you're, you know, your PhD, for example might have been a small qualitative study of 15 people. How do you then manage that shift? Not saying that's what yours was, but just as an
No,
example.
yeah. I think it came from me hearing anecdotally from advanced practice nurses that there was a problem for older people in care homes. So somebody came
Okay.
to me and said, we're really struggling with this group of breathless older people, and we think handheld ultrasound could help, but we don't know how to go about researching it. Will you help us? So that's where the problem came from. And then when I spoke to others, so, you know, cardiac physiologists like myself, cardiologists, their experience wasn't the same. they said there is no problem with access. There isn't a difficulty or an underdiagnosis or underuse of echo. And we don't see that. We think people are being diagnosed and managed optimally. But of course, each of those professions only see the patients they see. Okay, and so the nurses with the very elderly patients in care homes only had that perspective because they've not worked in a specialist service, and then
Yeah.
vice versa for the ones in the
Yeah.
specialist. So I thought I'm going to have to actually get the evidence for this. So I
Okay.
in my grant, one of the steps or the work packages that I put together was to try and map using population data in Wales, what is that diagnostic pathway for heart failure? So
Ah.
if we take people with a diagnosis of heart failure and look back in the electronic health record, to what symptoms they had, how long they had them for, what tests they had and when. Then once they had the diagnosis, what medication were they put on and what were their outcomes? So I
Hmm.
got funding to look at that with the SAIL data bank and with data analysts. And it was been my first time doing it, but it means I've now mapped what it looks like from the perspective of Wales, not just
Yeah.
specialist care
Yeah. Yeah.
and
Yeah.
not just elderly care or
Yeah. Yeah.
community
Yeah.
care. And actually, the data appears to support the nurse's perspective.
I
So
wish I
that's
could say I was
interesting.
surprised, but I'm not.
No, it's been interesting because it's meant I've been able to go to people with concerns that this didn't need to be done and say, the data suggests it does need to be done, and this is what it's showing. So that's how that came about, is because the clinical problem that I had designed a solution to test,
Yeah.
people were a bit, I'm not sure this needs to be done. Surely we could just carry on
Interesting.
doing what we're doing, have more echocardiographers in hospital, just carry on, but do more of the same. And I
Yeah.
was kind of saying, I don't think more of the same is going to work here. And this is the evidence to support it. So that's where it stemmed from. And the skills that I'm developing through that work, I'm hoping to then apply to my other end of life newborn screening
Yeah.
project, because longer term the idea is to start looking at interventions that improve children's health and outcomes
Yeah.
from congenital heart disease, and I'm going to need to look at the electronic health data for that.
Yeah.
So the idea is, maybe longer term, these are skills that I'll continue to
Yeah.
develop and build on. And it's gone from Wales to international because the children's work that I'm developing is with a team in Mongolia. So
Oh.
I've gone from tiny physiological quantitative data set to Wales heart failure mapping and trying to design a solution, to then international potential collaborations and exploring how to use those skills somewhere else, which I never thought I would
Wow.
do. I really never thought I would do, but it's just saying yes, talking to people, and then working out if there are opportunities that we can share expertise and ideas, and going from there, really.
Fascinating. Oh my goodness. Love it. My last question before we start wrapping up is around that last bit that you were just explaining, that and that connection to the American tech company
Mm.
that is now facilitating, encouraging, enabling, whatever word you want to use, your research that you're doing in Mongolia. How did that come about?
Yeah, that's really interesting, and I think it says a lot about needing to be visible as a researcher.
Okay.
So the American company was looking for UK academic partners to help provide sort of clinical and scientific expertise to develop their product. So they had an idea, they're dealing with the innovation, they've got the engineers, but they don't have necessarily the clinical skills or the scientific research skills. And they wanted to partner with an institution who would support them on their journey to getting this screening ultrasound device to market so that it could be useful. And the thing that is really important about that company is that they're designing it specifically for a low resource remote environment. So they were
Right.
traveling around and they looked at Wales as a potential site to develop their a headquarters for their business, and
Mm-hmm.
therefore the universities that could support. And I was asked by my university, will you come and meet them? They're coming for a visit. Will you come? We know you do ultrasound research in this space. Will you come and meet them? So I did. And I was really motivated, having heard their CEO talk about what they were trying to do and how to support them to do this independent, rigorous investigation of whether this device could do what they wanted it to do.
Yeah.
And that's my role really, is to guide the clinical investigation of it in the
Okay.
healthcare setting. So they've got other people involved with the AI research
Right.
and the engineering research. My role is really, as a clinical scientist, how might this be implemented? How should we test whether it works as intended? So
Mm.
that when they sell it, they can show that their claims are met.
Yeah.
That's been my role. So we kind of developed that from there. We helped them with prototype development in the university, not just me, other people in the university. And then I managed to get funding for a PhD student to work with us on the project. And we said to them, look, if we're going to design a clinical investigation for this device, we really should work with the people who you intend to use it.
Mm.
And that's not necessarily, yes, people might you find it useful in Wales because we've got rural communities and all
Yeah.
the rest of it. But actually, you're designing it for a much lower resource environment than Wales. So why
Yeah.
don't we go and see those lower resource environments and look at the different challenges of
Yeah.
implementing a diagnostic test in those areas. So that's how our trip to Mongolia came about. I got a grant, a travel grant to go and share knowledge and expertise with Mongolian pediatric cardiologists. So we spent only a week, but we visited we visited the special maternity and children's hospital in the capital city, and then some more rural hospitals to understand how different it is to get a new test in the pathway there and what their concerns would be with using it. And then since then, prototype is developed further. We've managed to get more funding to bring the Mongolians to the UK. So that happened in November. So they came and we developed ideas further around research, and they went to see different healthcare provision for children with heart defects or suspected heart defects in Wales and in Bristol. Um,
Mhm.
and they've then taken all of that knowledge about how practice is different here back to Mongolia. And so this is way beyond a clinical scientist's job, right? Because I'm just echo. But it's not, because it's about how they use ultrasound in their healthcare system. So now we've got more ideas developing around what we could do between the UK and Mongolia in terms of other research beyond this device.
But again, I think for me, the absolute, like, I don't know what the right word is, but it just, like, your desire and how you, like, if we scroll back to the beginning of our conversation, why you said you got interested in research, how you got interested in research, although there's been slight shift in what the theme is, the reality, as I see it anyway, is actually you're doing exactly what you set out to do, because you're trying to go further upstream and discover ways to better implement, use technology around ultrasound of the heart in order to better determine people's care pathways, so that those care pathways become more efficient
Yeah.
and that they are put on the treatments that are going to be right for them, or receive the right interventions or whatever those things are. And that actually, because of your PhD, because you were visible, because of the connections and the networks you've built, you've actually managed to quite quickly, because you said you finished your PhD 2016,
Mm.
2017, develop a program of international research, which is incredible.
Well, it's
Very
not quite, but it's getting
inspiring.
there. It is getting there. Yeah. So I think, you know, people don't talk about this often enough, I don't think, but it's come down to finding my why. I think finding what motivates me, and I didn't know that at the start of my PhD, and I now know it is healthcare inequalities. That's what motivates me. And I am driven, like super driven, to share anything I've learned or any skills that I've got that try to address that. And I feel like there isn't enough said about finding the passion that lights that fire in your belly for research and then having the courage or the confidence to focus on that. Because
Mm,
sometimes there's a need to, you feel like you need to do research because you've identified that there is a gap and you might be able to fill it, or somebody has suggested to you that something might be possible. But probably if it really doesn't float your boat, you're better off
mm,
saying no to it.
yeah.
And then finding ways to do stuff that really matters to you, because we get so much in the way of grant rejection, negative feedback from papers. It can feel hard. I mean, it's a very
Yeah.
satisfying job, very rewarding, but it feels hard. And I think what makes those things more bearable when the rejections come back, and what keeps you going and with the perseverance and determination, is that underpinning motivation of, I'm contributing to something bigger than me, and this is what I want to do, and I'll try. And I might not be the best person, or I might not be the most experienced, but I am willing to give them my time and share with them what I know, and that's a start.
Yeah.
So, you know, that's how I'm moving forward. I've given up on feeling like I'm an imposter, because that's how I started. And I now realize, actually, the feeling like there's always more to learn, and feeling like I haven't settled for comfortable, is good. The fact that I'm often feeling uncomfortable is a good thing, because it means I've not settled. I don't
Yeah.
want to settle and just be, just continue doing the same thing all day, every day, never challenging the status quo, never thinking there could be a better way to do it. And actually, those things that people call imposter syndrome, those feelings that I feel still every week, and I've been in this role for 20 years now, I still feel those feelings every week. I just think that makes me a better clinical academic. So I've just got to embrace it.
Love it. Oh my word. I can just sit and listen to you talk. You are the medicine I needed today. Quite
I don't know about that.
selfishly. Huh? No,
I don't know about
definitely. It's definitely like so much of what you're saying. Like, it's just, I think we were kind of talking before we started and hit the record button about how research can sometimes feel isolating and how you end up doing quite a lot of it independently. And I think your willingness, not just to share with me, but to share publicly with everybody who's going to listen or watch this episode, that actually these feelings they're not a sign of trouble. They're a sign of you're doing the right thing, is so reassuring because
I
it
think
just,
the key thing is, you can't let those feelings overwhelm you into paralysis. That's the difference. I think it's
mm,
feeling scared, feeling nervous, but knowing it's the right thing to do for the bigger picture and just going with it and
mm,
accepting there will be failures. I think if it's paralyzing you and stopping you from making action, then probably there is a need to call it imposter syndrome and to try and find a way forward, isn't there? But
yeah.
but it's not allowing yourself to be paralyzed by it.
But I think from conversations I've had, I think clinicians struggle with that more. Like, um, so I've listened to, and I've said this before, I've listened to loads of entrepreneurial podcasts. when I was doing my PhD, just because I found them so inspiring. Because similarly, like, yes, it might have been about a business idea or a thing that they had made, but they made friends with rejection.
Yeah.
And I think in our clinical backgrounds, because our training and so much of our professional experience up to the point of starting research, we can't make
No.
mistakes.
Yep.
Rejection is life or death or harm. And so I think there's a real big transition that happens when a clinician becomes a researcher, regardless of what profession they're from, because you have to learn that failure and rejection isn't necessarily as bad as you thought it was.
It's the only way to learn. I think fail fast, learn quickly is the saying, isn't it? And definitely you cannot innovate unless you take risks.
Yeah,
And if you take risks, there is going to be failure. But I
yeah,
think what serves us well from our NHS background is in thinking of the unintended consequences of the failure and mitigating them, because we're very good at doing that. And that's a real strength in research. It's really helping us to think more holistically about all different perspectives of our work and the outcomes, which maybe people from a different background wouldn't think about it in the same way. So let's use that as a strength.
agree. Love it. I love it. I love it. Right. I just looked at the time. One last question. Any last top tips or reasons why somebody out there who might be listening to this, who is like you, a cardiac physiologist and a health scientist, why should they do research?
Um, I think the most important reason is probably so that we progress in providing better patient care. I think, if you settle for comfortable, who does that serve? It doesn't serve the patient. So I
No.
feel like not just research, but proper clinical audit, service evaluation, all of the steps along the
Yeah.
way, if you like,
Yeah.
not just sort of primary research. Like, they're all super, super important for challenging the status quo and moving things forward. How can we do a better job? And that research is not just important from a personal satisfaction point of view, it's really important for your organisation to provide better value
Mm.
healthcare and to be more efficient. But also, it improves things like recruitment and retention of staff in the profession, in your department. And it improves patient outcomes, obviously. That's why we do it. So it's kind of like win-win-win. If you don't do it, or you don't have a culture of research in your department, then you are likely to struggle with things like recruitment and retention, or having the best outcomes or the lowest complication rates, or whatever it is you're looking at in your work. So, I think it's a no-brainer. We've got to help more people to start on the path and not to feel like it's something you only do when you're really senior. Like, you've got to be a band 7 before you start. No, rubbish, rubbish. It's a mindset. We can't be stifling out this natural scientific curiosity. We've got to encourage people at all bands and grades to go, well, why? Why are we doing it that way? How could we do it differently? How do we know that that works? And start the ball rolling and encourage that really, really early on. I don't think we do enough of that.
Agreed. Brilliant words to end on, Emma. Thank you so much for being willing and answering my cold call through Twitter
It's okay.
to join
Thank you
me
for
today
asking
on the
me.
pod. Yeah, to join me on the podcast. It's been wonderful getting to hear more about your journey, and even more so getting to hear about your research. And I look forward to seeing the outcome and those papers get published.
Great, thank you. Yeah, I'm working hard on writing at the moment, so hopefully it won't be too much longer.
Fingers crossed. For everybody out there listening, if you want to find out more about Emma, read about where she's researching and things related to what she was talking today, go into the description of the episode, because it'll all be in there for you to click on links and be able to follow her so you can get the updates to her research as well. And I think with that, we're going to say bye for now. So thank you so much for joining, Emma, and I will speak to you soon.
Thank you.
Don't go away. Up Next, we have the top 3 takeaways from this week's podcast by Dr. Rosalind Austin. There's something special about having a conversation with somebody and finding out that you have so many things professionally in common. And that's exactly what happened in today's episode with Emma for me. I've followed her, I've seen her research, I've been inspired by her research on social media. But hearing more details about the research that she's done, but more also the research she hopes to do and the researcher she's trying to shape herself into has just made me be like, so inspired, because she's managing to do many of the things that I hope to do and build in my career. And rather than seeing that as a thing to be competitive about, it just reassures me that there's hope maybe for me as well. My top takeaways from my conversation with Emma today is the first one being have a team approach. And I think not enough is said about that. When you're doing your PhD or starting masters or even being research curious, the focus is so much on what are you going to do, how much you're going to do, and the fact that you're going to run and do this program of research independently. And even when I was doing my PhD, the more I think about it, is I always found, and maybe because of my background as a research nurse, that I knew that research in reality takes a team. And so I wanted to involve more people within my research, and hearing Emma's experience and how her building her team of lots of different disciplines, lots of different people, has really helped and shaped and pushed her to be more confident, to think bigger, and to have a larger research program of research really has been the key to her progressing post PhD. So I think it's a really important thing to stop and give yourself permission to think about is how are you progressing from your research being PhD driven, where you to a degree have to do it independently because it's an educational process. How do you then progress that in your postdoc period to having a team approach and to building those individuals who can supplement and create the right team so that your grants, your research will be more successful? My second top takeaway, again, that postdoc transition period, is to expand your level of expertise. And she used the term, and I thought it was really interesting how her PhD was hypothesis generating, or helped her develop more questions and identified where she could see there being real holes in the evidence and real need for research in order to drive improvements to clinical care. But in order for her to answer those calls, she's having to upscale. And yes, she's doing that through changing the team around her, but she's also doing that through challenging her own level of expertise and shifting from, small local data sets to big data sets, to the point that she's even hoping to incorporate AI into it. So again, I think it's that challenging transition between postdoc of taking those ideas and converting them into a bigger project, which will require teamwork, but it also requires you expand your expertise. Finally, the third takeaway for me from her was be visible. And that's tricky. That's tricky to say. And I found it really interesting that she was talking about that, because in the top 10, or the rapid 11 questions, not top 10, in the rapid 11 questions, she talked about how she's a person who craves silence, where noisy, busy environments can be challenging. And yet she took purposeful steps to ensure that she was visible within her institution within her professional group so that when opportunities came up, her name was thought of, her skills were known. And I think it's something that we as clinicians aren't necessarily good at. And whether that's because of how we're trained, whether that's because of the institutionalization that happens working in a hospital, where you just assume that people are going to figure out what you do and they'll find you. And in research, as much as it's a small world, there is a bit of a need to become visible, to have it so that people know who you are and that they know about the research that you're doing. And so I think as a takeaway, it's really important to go away in this corner by yourself, have a talk with a trusted advisor about how it's right for you and who you are to become more visible so that you're able to expand your research network and your research influence. That's it for today. This one was a little bit extra longer. I hope you enjoyed it as much as I did while I was recording it and even editing it back. I found her really inspiring, just the way she thought about things and the way the actions that she's taken, and I hope you did as well. Remember to check out the description below. It will have more details on how you can follow Emma, hear about more about her research, and get connected to her so you can keep track of her research journey. And yeah, remember to like, comment, and subscribe, especially on the YouTube channel, but also on most podcasting platforms, you can leave a review. And doing that just feeds the algorithm. I don't get anything from it other than a bit of, yay, somebody's listening. But it's very much appreciated to everybody who's doing that and giving me that feedback. So keep doing it. Right, that's it for this week. I will see you all again in another 3 weeks. Thank you so much for listening and keep asking why.